We're here at the 2016 CROI, and we're here talking about TB today and updates in science. And we're here with Petros Karakouzis, who's with Johns Hopkins University in Baltimore. And we're here with Sarah Auld, who's with Emory University in Atlanta. And we appreciate them being here to do this. And it should be interesting. There's so much going on in the world and so many diseases that this is yet one that hasn't quite gotten there yet, but we're almost there.
Hopefully,
so
yes.
let's let you talk first, Sarah.
Well, thanks so much for having us. It's a real pleasure to be here. I think that there's been a lot of exciting research in the last couple of years in TB and a lot of progress made. The WHO has announced that globally TB rates are declining, which is really great. One of the areas I work in is drug-resistant TB, and unfortunately that seems to be on the rise. And so we're trying to garner more resources and get some more information about how to really fight that plague and problem.
So both the XTR and MDR and XTR, which, can you explain what those terms
Yeah,
represent?
so MDR is multi-drug resistant TB, and that's TB that's going to be resistant to our two most powerful first-line TB drugs. And XDR TB takes it a step further, and you have resistance to those first-line drugs as well as to our most effective second-line drugs. And so then patients are left with regimens that are really not as effective. They have a lot of side effects when you use them together. They're more toxic. They cost a lot more money. And the cure rates are pretty abysmal, about 25% globally for people with XDR TB.
Really?
And
so
mortality rates 40 to 70%.
I was going to say, so they just die. There's
Yeah.
no other options.
Yeah.
So how do we surmount that problem? It seems like this is something that we should work hard.
That's the hope. I think it's really going to take a multi-pronged approach. We need to be thinking about it from the perspective of preventing more XDR from arising, and then also really working on treatment regimens that are going to be more effective and less toxic to patients. And I think both of those things are happening in the TB community.
So how do you acquire the XDR TB?
So that's actually the project that I'll be presenting on here at the conference. We did a study in South Africa where we looked at where's the XDR coming from. And there's really two possibilities. One is that patients who themselves had the MDR TB were taking those second-line drugs for their MDR TB and failed that. And so they developed additional resistance on treatment. The other possibility is transmission. And so one person with XDR TB directly transmits it to another person with XDR TB. And we found that anywhere from 70 to 80% of the XDR TB in the KwaZulu-Natal province of South Africa is due to transmission, which is pretty astounding because conventional wisdom for a long time had been that if we can just do a better job treating the MDR TB, we'll head off that problem of XDR. But if transmission is the major player, then improving our MDR programs is not going to be sufficient. We also need to think about infection control and outreach and early treatment to try to prevent the transmission from individuals.
So the challenge is to identify the XDR TB and do whatever you can to let them know that they have to be careful. So the transmission is so easy. It's not something that is through sex. It's through coughing and through sneezing.
Yeah, it's airborne. And so we found in our study, we did a social network analysis where for the patients with XDR TB, we interviewed them about their contacts, where they spent time, which hospitals they'd been in. And we found many instances where XDR was being transmitted in the home from one family member to another. We found a couple of instances where it was being transmitted in the community through, for example, a church group or through schoolmates and things like that. And then also many instances where people were in the hospital at the same time and certainly had the opportunity to transmit from one to another. And so in order to head that off, it sort of depends on the setting. In the hospital, we need to work on our isolation of patients who have resistant disease so that they don't have the chance to spread it to someone else. In communities, we need to be doing better outreach, identifying people early, and then getting them on treatment to reduce the likelihood that they're going to pass it on.
And you have a lot of, you have an issue with people who can be infected but not in acute stage. So
Yes.
It depends upon your immune system as to whether you're actually presenting with the disease state.
Yeah, so latent tuberculosis, where you'll have the infection in your body but not actually active disease, is also a concern because right now we have no treatment for latent XDR-TB. There are studies underway to look at treatment for latent MDR-TB, someone who's been exposed to someone with MDR, that multi-drug resistant TB. And we're going to try to prevent them from developing active disease in the future. But for XDR, we don't have that right now. So I think that's a real critical need for the research community to work on in the coming years.
And Petros, I'm going to let you weigh in here because I know it looked like you might want to say something.
Yeah, I agree with what Sarah's been saying, and I'll take it even a step further. For latent infection with drug-resistant strains, we don't even have really a way of diagnosing that. I mean, right now, the only way we would know that is if there were a history of exposure to somebody with a drug-resistant strain of TB. And right now, we don't even know if people, because the problem with latent TB infections, you have very few organisms in your body. And there's no way really to...
So there's not a test you can do, like a skin test? Or?
There is a skin test, but it just tells you whether you have...
TB or not.
Yes, whether you have infection or not. It doesn't tell you anything about the drug susceptibility. And so that's something that we need to work on, is to find out, if somebody has latent infection, do they have infection with a resistant strain? Mm-hmm. One of the other exciting things, I think, coming up is that there are new studies to look at new regimens to treat MDR and XDR-TB. The TB Alliance is an organization that kind of organizes these studies, and there's a pilot phase 3 trial now called the NIX-TB, where it will, where patients will get, patients with XDR-TB will get 3 drugs that are not included as part of the first-line regimen. And the hope is that they can be treated in 6 to 9 months, just as they would in a drug-susceptible case.
So is there a way for a person to, who has latent MDR-TB to acquire latent XDR-TB without presenting in the disease state?
You mean?
Or, I mean, in other words, I guess the question is, if you have MDR, is that going to wall off the ability to get XDR-TB? Or do you know that?
If you had contact with someone with XDR, you would be just as likely, or just as much risk.
On
certainly.
top of that, and
Mm-hmm.
okay.
This is actually one of the problems of TB, is that even acquiring infection doesn't provide natural immunity. You can get reinfected with TB, and so that actually poses, if you think about it, it's very complicated to come up with a vaccine if the natural infection doesn't provide immunity against subsequent infection.
So you can be reinfected and reinfected.
Exactly.
So this is all the more reason that we have to find a way to annihilate this pandemic, because it is something that can continue to persist in a community and not permit resolution.
Absolutely.
Yeah. So are there efforts? Do you mostly work in science? The World Health Organization works for these issues, right? Because we just actually interviewed Meg Doherty, who's working with the World Health Organization. So what is being presented here at this conference that would be in that direction? Is there anything that gives some hope?
For true annihilation?
Annihilation, yeah. Because I guess it would be new drugs, which you were saying is something that they're definitely interested in. But is there any research that's headed realistically in that direction?
I mean, I think some of these new regimens that have come out, there have been, for the first time in nearly 40 years, 2 drugs that have been approved in the last couple of years, specifically for TB, bedaquiline and delaminid, and those are being rolled out in many of these high-burden settings. And I think on both the part of the scientific community and the patient advocacy community, there's been a real effort to get these rolled out quickly so that people who are dying will have access to them.
And how are they going to implement the introduction of those into the community? Because it seems like this is a very precarious situation. I mean, if you develop resistance to those, there already is nothing for XDR-TB. So is this something that will be in addition to helping XDR-TB patients, or is it just for MDR-TB?
I'm certainly most familiar with the situation in South Africa, as that's where I've done the majority of my work, and there the government's had a very concerted program where they're being very thoughtful and careful in how they're rolling this out. But as of the end of last year, end of 2015, they had over 1,000 patients who've been started on this new drug, bedaquiline. And these are patients who, great efforts are being made to retain them in care and to try to preserve the power and utility of this new drug.
So let me ask another question, because I know this gets really tedious and complicated, and I know our people are watching, the audience, about this kind of question. So a person is ostensibly treated successfully for MDR-TB, then they have a virgin possibility of getting the same disease, MTR-TB, from someone who has MTR-TB or XDR-TB. It doesn't make them automatically go to an XDR-TB. It's just they're starting all over again with the same risks for whatever it is that's out there.
Yes.
They're just cured of whatever it was that they had.
Yes.
But as you said, no vaccine effect at all. So, but the vaccine seems like something that would be a very good step to go. Is there any people that are working on that, realistically?
Yeah, I mean, there are several vaccine studies. I can tell you that there's not, at least from my perspective, a lot of hope right now for a new vaccine anytime soon. You may know that there is a very old vaccine called BCG that's given in many parts of the world, and in fact is still given in areas with very high incidence of TB. It probably is somewhat effective in preventing certain kinds of childhood TB, particularly TB of the central nervous system, like TB meningitis. But it certainly doesn't work well in protecting adults against TB. And so it's clearly not an effective vaccine, even though it's the most frequently given vaccine in the world today.
So where are you, each of you, headed for the research that you're each individually working on?
Yeah, so I wanted to reiterate one of the things that Sarah said in the beginning, which is that one of the perhaps most effective ways of preventing and curbing the further spread of drug-resistant TB is by doing a better job of treating drug-susceptible TB. So that means going out and active case finding, diagnosing, improve diagnostics to find these people and treat them more effectively. But this gets into my research, which is one of the problems with treating even drug-susceptible TB is that you have to take multiple drugs, 4 drugs for 2 months, and then additional 2 drugs for anywhere from 4 to 6 more months. So a total of 6 to 9 months of treatment just to cure.
Issues, yeah.
Exactly. So that leads to problems with adherence. In many parts of the world, this is done under what's called directly observed therapy, which means that because it's a public health risk, it's not just at a risk of the individual. So it's very resource intensive, and for resources that could be diverted elsewhere. So what happens a lot of times is that people take the antibiotics for a couple of weeks and they feel much better and they stop taking them, and that leads to the problems of drug resistance. So one of the things that I'm working on in my group is to identify new strategies to target these organisms that are responsible for the long duration of treatment. We think that they're sort of dormant, to put it kind of in an anthropomorphic way, they're sleeping, so the currently available drugs don't work very well at killing them. So we're trying to find out new ways to target those bacteria so that we can shorten the duration of treatment, making it easier to have adherence and prevent drug resistance in the first place. One of the interesting things that we're working on is to do what's similar to what is being done in the HIV field, which is a kind of shock and kill strategy, which is to kind of wake up these organisms. Because it turns out that the antibiotics that we have to treat TB work well against actively dividing bacteria. They just don't work well against dormant bacteria. So if we can wake them up, then we can perhaps kill them more effectively. Of course, we have to do this in a safe way that doesn't make the infection go out of control.
Right. And we dealt with that early on in HIV. I think there was some sense that we were with IL-2 and so forth. So is there some way that we can see this, the drugs that are out there right now becoming more effective through this new idea of of implementation, proper administration, and I mean, are you working on that yourself? I mean, this implementation?
Mm-hmm. Not the implementation at the community level. We are involved in developing the regimens that then can be tested. In fact, one of the other important areas, I think, is the repurposing of existing drugs so that we can accelerate the pipeline, basically. And that includes agents that may not have any direct antibacterial activity, but they may modulate the host immune system so that it is more effective in killing the bacteria. So one example of that my group is working on is the lipid-lowering drug statins. That it's actually the most frequently prescribed drug in the U.S. today. People use it to lower their cholesterol and for their cardiovascular benefits, but it turns out that in the mouse model, when combined with the first-line anti-TB regimen, it actually is able to shorten the duration of treatment. So we're actually interested in the next 2 years to do a clinical trial in South Africa of patients randomized to receiving either the first-line TB treatment or the first-line TB treatment plus a statin.
So the direct observed therapy is in a pill once a day, or?
In many cases it is available as a single pill, but oftentimes you have to take several different pills.
The question I would have is, we have now some new drugs that are coming out for HIV that are implants, so you can administer it, inject it every 2 months or 3 months. Is this something that you're looking at in TB that as an injectable? Because it really would solve the problem of the intensive administration of the direct observed therapy.
Yeah, that's true. They have to be in a depot form in the sense that they can be slow release. Many of the drugs that Sarah talked about for the second-line regimens are injectables, in fact, but those are drugs that we want to avoid because they're given daily and they're very toxic and costly. But what you're saying is something that's injectable that would be...
Depot injection,
yeah,
as you
exactly.
say.
I'm not aware of any drugs that have been formulated, but it's certainly something that should be considered.
Maybe I made an idea here for you, so you can move forward.
Take it and run with it.
So, Sarah, do you have any other pieces that... I mean, you're presenting a work here today, as you alluded to earlier, but can you tell us more specifically about that?
I mean, I think some of it is what I mentioned, just that we have been able to identify these locations of transmission happening in both homes and hospitals in the community, which I think can be a bit of a wake-up call to some of these places with high burdens of XDR. And I think it's also useful for TB programs, TB and HIV programs, so that they can think about how to direct their resources to prevent this problem of drug resistance from getting bigger.
Well, you've both been very helpful. I think we've covered it pretty well. Do you not agree? We've managed to get all the pieces to it. I know that you're all both focused in specific areas of research, but you know the field, and that's why we asked you to do this today. Thank you very much.
Well, great. Thank you so much.
Thanks.